welcome to the deep dive. Today, we're really zeroing in on a very important topic, neutropenic sepsis. It's something you might encounter, especially in patient care, or maybe you just want to get a better grip on it.
Absolutely. And our mission for this deep dive is pretty clear. We want to pull out the essential high-yield information from our notes on neutropenic sepsis.
Make it clear, make it memorable.
Exactly. Useful for revision, useful for understanding. We'll break down the key bits, maybe use some memory aids.
Yeah, cut through some of that complexity you sometimes find. If you've ever felt a bit overwhelmed by medical jargon, well, this is for you.
Let's dive in.
Okay, let's start right at the beginning. What is neutropenic sepsis in simple terms?
Right. So fundamentally, it's a life-threatening condition. It's this combination of having a really low count of neutrophils.
Those are the key infection-fighting white blood cells.
Precisely. So very low neutrophils, and then developing a severe infection on top of that.
Okay, low cells, bad infection. Are there specific criteria, like numbers we look for?
Yes, there are. The classic definition involves a fever, usually 38.3 degrees Celsius, that's about 101 Fahrenheit or higher,
Okay, fever?
and neutropenia, specifically a neutrophil count below 0.5 times 10 to the 9 per liter. Or you might see it as less than 500 cells per microliter. Same thing, different units. And this is usually in someone who's immunocompromised.
Right, often someone getting cancer treatment.
That's the crucial context. It's frequently a complication of cancer therapy, especially chemotherapy.
And there's a typical timing for when it pops up.
Yeah, you often see it about 7 to 14 days after a chemo cycle. That's when the neutrophil count tends to hit its lowest point, the nadir.
Got it. So, just to recap the definition clearly, we're looking for a neutrophil count under 0.5 times 109 in someone getting cancer treatment who also has a fever over 38 Celsius or other clear signs of sepsis.
That's spot on. That's the picture.
Okay. So, moving on to etiology, what actually causes this whole situation to develop?
Well, as we touched on, the primary driver is often the cancer treatment itself. Chemotherapy, radiation therapy. They're designed to target cancer cells, but they can also affect the bone marrow.
Where the neutrophils are made.
Exactly. So you get this suppression of the immune system, leading to that drop in neutrophil numbers. That's the underlying mechanism.
So the treatment creates the vulnerability. And then what kind of infections actually take hold?
It's a really broad range, honestly. Because the immune system is weakened, various pathogens can cause trouble. It could be bacterial, viral, fungal, sometimes other types too.
So basically the door is open for lots of different invaders.
Pretty much. The body just doesn't have its usual defenders.
Okay, that makes sense. So knowing that, who is most at risk? What are the key risk factors we should be aware of?
Right, risk factors. Well, number one is definitely undergoing chemotherapy or radiation therapy. That's the big one.
Makes sense.
Then, obviously, the low neutrophil count itself being below that 0.5 or 500 mark is a major risk factor.
And I guess how long you stay that low matters too.
Absolutely. Prolonged neutropenia, where the count stays low for an extended period, definitely increases the risk.
Okay. What else?
Having a central venous catheter like a Hickman line or a portacath can be a risk. It's a potential entry point for bugs.
Right. A direct route in.
Also, a history of previous infections suggests some underlying susceptibility, perhaps. And certain types of cancer, especially hematologic malignancies like leukemia or lymphoma, carry a higher risk, plus other underlying medical conditions that might affect immunity.
So it's a mix of the treatment, the specific counts, how long they're low, access points like catheters, and the patient's history and underlying condition.
You've got it. It's multifactorial.
Let's dig into the pathophysiology a bit more. What's the sequence of events happening inside the body?
Okay, so you start with that compromised immune system, mainly the lack of neutrophils, our frontline soldiers against bacteria especially.
Right.
Then the person encounters some kind of infectious pathogen, could be from their own gut flora, could be from the environment.
And because the soldiers are missing.
Exactly. The body's ability to fight off that pathogen, to contain it, is severely impaired. The few neutrophils that are there just get overwhelmed.
Leading to?
Well, the pathogens can then multiply pretty much unchecked. They can spread through the bloodstream, leading to this widespread systemic infection, that's sepsis, compounded by the neutropenia.
Which explains why it's so dangerous and progresses so quickly.
Precisely. Time is absolutely of the essence.
Okay. Now, sometimes a patient might present with a fever and signs of infection, but they don't have that low neutrophil count. How do we differentiate? What's in the differential diagnosis?
That's a really important point. If the neutrophil count is normal or even high, then neutropenic sepsis is, by definition, not the diagnosis.
So what else could it be?
You'd think about more common things, perhaps straightforward viral infections, or non-infectious causes of fever, like some inflammatory conditions or even drug reactions.
Like a drug fever.
Yeah, that can happen. Or it could be another form of sepsis, maybe bacterial pneumonia or a UTI, but occurring in someone without neutropenia. The management approach might differ.
So the neutrophil count is the real linchpin for diagnosing neutropenic sepsis.
It really is.
What about how common this is, epidemiology-wise?
It's actually tricky to get exact prevalence figures, but we know it's a common and serious issue in the UK, definitely.
Particularly in cancer patients.
Yes, particularly among patients receiving treatment for cancer, and maybe even more so in those with blood cancers, hematologic malignancies, as their bone marrow is often directly affected by the disease itself, even before treatment.
Right, so a significant clinical problem. Let's think about presentation. What signs and symptoms should make someone think, could this be neutropenic sepsis?
The absolute classic sign, the one mentioned most often, is fever. That temperature of 38.3 Celsius or 101 Fahrenheit or higher.
Okay, fever first. What else?
Chills often accompany the fever. You might see a rapid heartbeat, tachycardia, low blood pressure, hypotension is a worrying sign. And just general symptoms like feeling profoundly weak, fatigued, sometimes an increased breathing rate, dyspnea, and in severe cases, altered mental status, confusion. That's a red flag for severe sepsis.
Are there usually signs pointing to where the infection started?
Sometimes, yes. You might find signs of a localized infection, maybe some redness, swelling, warmth, suggesting a skin or soft tissue infection, perhaps around that central line site we mentioned.
Or maybe a cough?
Exactly, or a cough, shortness of breath suggesting pneumonia. But sometimes you don't find an obvious source. Initially, the infection seems to be primarily in the bloodstream.
Okay, so you suspect it based on these signs, especially fever in an at-risk patient. What investigations need to happen, and quickly?
Speed is key here. First off, blood cultures. Absolutely vital. You need to try and identify the specific organism causing the trouble. Ideally, take them from both a peripheral vein and the central line if one is present.
To guide treatment later.
Precisely. And you need a full blood count, FBC, with a differential. That's essential to confirm the neutropenia to get that actual neutrophil number.
Right, confirm the neutropenic part. What else?
Imaging can be really important to find the source. A chest X-ray is often standard.
Looking for pneumonia.
Yeah. And depending on the situation, a CT scan might be needed, maybe of the chest, abdomen, pelvis, if you're looking for an abscess or a deeper infection source.
Okay.
And then you'll do other tests to check organ function, kidney function, liver function, and assess the overall severity of the sepsis, maybe checking lactate levels, for instance.
So a full workup.
Yeah.
Confirm the neutropenia, find the bug, find the source, assess the damage.
That's the goal, yes.
Yeah.
And do it fast.
Which brings us neatly to management. This sounds like an emergency. What's the immediate plan?
It absolutely is a medical emergency. Immediate hospitalization is usually required. The cornerstones are prompt broad-spectrum antibiotics and supportive care.
How prompt is prompt for those antibiotics?
We're talking ideally within an hour of recognition, seriously fast, often using something like piperacillin with tazobactam or maybe a carbapenem depending on local guidelines and resistance patterns.
And you start those before you even get the FBC result back, confirming the neutrophil count.
Yes. If you have a patient known to be at risk, say, post-chemo, and they have a fever or look septic, you start the antibiotics. Don't wait. The risk of delaying is far too high.
Wow. Okay, so hit hard, hit fast.
Exactly. There might be some very specific low-risk cases assessed by specialists where outpatient management with close monitoring is considered, but generally it's admission and IV antibiotics.
What happens if the fever doesn't settle after starting those initial antibiotics?
Good question. If the fever persists after, say, 48 hours, you need to reassess. You might broaden the antibiotic coverage, perhaps add vancomycin if you're worried about resistant gram-positives like MSRA, or switch to something broader like meropenem if you haven't already.
And if the fever still doesn't break?
If you get to about 4 to 6 days, the fever is still there, and you haven't found a clear bacterial source despite investigations, that's when you really start thinking about fungal infections.
Oh, okay, so you'd investigate for fungal causes then.
Yes, you'd specifically look for fungal markers or maybe do imaging like a high-res CT chest before just empirically starting antifungal drugs, although sometimes antifungals are started based on high suspicion.
Got it. What about GCSF? Does that play a role?
GCSF, or granulocyte colony stimulating factor, helps boost neutrophil production. Its role in established neutropenic sepsis is a bit debated, but it might be considered in specific situations like very prolonged or profound neutropenia, or patients with signs of severe sepsis or shock. It's not routine for everyone.
Okay, so it's more of a specialist consideration.
Generally, yes.
Yeah.
The core is identifying the source if possible, tailoring antibiotics based on culture results when they come back, and managing any complications like septic shock with fluids, sometimes vasopressors, and other supportive measures.
It sounds like a really intensive process. What's the outlook for someone who develops this? What's the prognosis generally like?
It really varies quite a bit. It depends on several things. What caused the neutropenia in the first place, how severe the actual infection is, how quickly treatment was started.
So that rapid treatment makes a big difference.
A huge difference. Early recognition and prompt, appropriate antibiotics definitely improve outcomes. The patient's overall health and any other coexisting conditions also play a significant role.
But it can still be very serious.
Oh, absolutely. Despite advances, severe neutropenic sepsis remains potentially life-threatening. Mortality rates can still be significant, especially if complications develop.
Which leads us to complications.
Mhm.
What are the main serious things that can go wrong?
Well, the most feared is progression to septic shock, where the blood pressure plummets and organs start failing.
Right.
Organ dysfunction or outright organ failure, kidney failure, respiratory failure requiring ventilation can happen. The infection can spread throughout the body, causing disseminated infection or abscesses in various organs.
And ultimately?
Ultimately, sadly, mortality is a major complication. And beyond the direct effects of the sepsis, there can be complications related to the underlying illness, the chemo itself, or the intensive treatments needed.
It really highlights why it's taken so seriously. Okay, let's try and consolidate some of this. Any good memory tips or ways to frame this for revision?
Definitely. For those risk factors, we could use mnemonic. How about chemo problems lead to infection catastrophe?
Okay, chemo problems lead to infection catastrophe. Break it down.
Sure. C for chamaridation, H for hematologic malignancy, E for extended or prolonged neutropenia, M for underlying medical conditions. Oh, maybe think ongoing treatment or just a factor like older age increasing general risk, although not explicitly listed earlier. P for previous infections, L for the low neutrophil count itself, and the second C for central venous catheter.
That's pretty comprehensive. Chemo problems lead to infection catastrophe. I like it. How about an MSRA style question to test the definition?
Let's try one. A patient is undergoing chemotherapy for lymphoma. They present to the emergency department feeling unwell with a temperature of 38.5 degrees C. Their bloods are taken, and the neutrophil count comes back as 0.4 by 109 L. What is the most likely diagnosis? And the options might be A, viral URTI, B, drug fever from chemo, C, neutropenic sepsis, D, pneumonia with normal counts, E, tumor lysis syndrome.
Okay, so we have fever over 38, chemo patient, and neutrophils definitely below 0.5. That points squarely at.
C, neutropenic sepsis.
Exactly. Ticks all the boxes. And for remembering the urgency of management.
Maybe something simple like fever plus low neutrophils, think ABCs.
ABCs.
Antibiotics broad spectrum currently, as in right now.
Oh, love it. Antibiotics broad spectrum currently. Gets the point across. Okay, one more question. Focusing on that immediate management, what is the single most important initial step in managing suspected neutropenic sepsis? Options. A, wait for blood culture results. B, administer broad-spectrum IV antibiotics promptly. C, give paracetamol and observe for 4 hours. D, obtain a CT scan of the chest. E, check C-reactive protein level.
Based on our discussion, the answer has to be B. Administer broad-spectrum IV antibiotics promptly. Everything else can follow, but the antibiotics can't wait.
Absolutely. That urgency is the key message.
It really is.
Right then, that brings us towards the end of this deep dive on neutropenic sepsis. We've covered what it is, that critical combo of low neutrophils and fever, or sepsis signs, especially post-chemo.
We looked at the causes, mainly treatment-related immunosuppression. The risk factors are chemo problems, Mnemonic might help there, and the pathophysiology, how the lack of defenders lets infection run wild.
Yep, and how to differentiate it, how common it is, the clinical signs to watch for, the essential investigations like blood cultures and FBC.
And crucially, the management. Immediate broad-spectrum antibiotics are ABC's supportive care, and then tailoring treatment and looking for complications like septic shock.
We touched on prognosis being variable, but improved by rapid action, and those serious potential complications.
We really hope this run-through has helped crystallize the key points for you, making neutropenic sepsis a bit clearer and easier to recall.
Remember those core concepts: low count, fever, act fast.
Definitely.
And maybe a final thought to leave you with, consider just how vital vigilance is in those at-risk patients. Even subtle changes, maybe just feeling a bit off or a slight temperature rise, could be the earliest sign. Maintaining a low threshold for suspicion is so important.
Well said. And if you want more resources, practice questions, and detailed revision material to help you ace your MSRA, do check out passthemsra.com.
And don't forget, there's also lots of great free content available over at freemsra.com to support your learning too.